Welcome, everyone. My name is Amanda Demmer. I'm the Program Coordinator for Community-Based Research Canada and the moderator for today's session, titled Engaging with Bereaved Parents in Substance Use Research and Policy Reform. Our speakers today are Heather Morris, Petra Schultz, and Rebecca Haynes-Saw, who will introduce shortly. Today, we also have two CBRCanada volunteers with us, Sonia and Dana, who will be supporting our event. This event is being recorded and closed caption is enabled. You can toggle this on or off by using the three dots on your screen. That'll open up more Zoom options. Today's session is the first of a three-part series celebrating community-based research excellence by highlighting previous winners and nominees of the CBRCanada Awards for Community University Partnerships and Emerging Community-Based Researchers. Before we begin the webinar today, I want to acknowledge that the CBRCanada Secretariat is situated on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. We have a mix of attendees today joining us from different locations across Canada, so I invite you to introduce yourself in the chat and to include where you're calling in from. This presentation today is brought to you by CBRCanada, a membership-based organization whose mission is to advance community-based research excellence in Canada by strengthening partnerships, building capacity, mobilizing knowledge, and championing CBR among individuals, communities, and institutions. We are a social enterprise funded entirely by our institutional and individual members. As part of our programming, we host events like these e-learning series events, the webinar and live discussion events. And we also host bi-monthly communities of practice for community-based researchers to gather and discuss. You can find more information on our upcoming events, as well as recordings and graphics from past events, all on our website. And Sonia will share our website link in the chat for you. In each webinar, we begin our events by reflecting on and amplifying the goals of the Truth and Reconciliation Commission's calls to action. In the spirit of reconciliation, CBRCanada is committed to engaging with and learning from diverse Indigenous peoples and communities across Canada, as well as addressing the Truth and Reconciliation Commission's calls to action. This month, we're highlighting call to action number 19. We call upon the federal government in consultation with Aboriginal peoples to establish measurable goals to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities, and to publish annual progress reports and assess long-term trends. Our speakers today will be talking about substance abuse and substance use. This call to action number 19, identifies substance use as one indicator of health inequity faced by First Nations, Métis, and Inuit individuals in Canada. CBRCanada is committed to continual reflection on the interconnections between truth and reconciliation and the various topics we approach using community-based research. Our agenda today will begin with the presentation by our speakers, followed by a chance for a question and answer period with them. This will be recorded, but the live discussion component, which will follow, will not be recorded. This live discussion will include breakout rooms where you'll have a chance to discuss themes from the presentation, centered around two discussion questions the presenters have posed, and we'll have a chance for a large group debrief following that. Sonia will share a link to a Google document in the chat with you that contains this agenda. Some final housekeeping before we begin. If you have any issues with the technology here on Zoom, you can send a private message in the chat to Sonia, who will be able to help you out. During the webinar portion of the event, please keep yourself muted and off camera. If you have questions for the presenters, you can feel free to enter these into the chat throughout the presentation, and they'll be addressed at the end during the live Q&A. Following this, when we enter the live discussion, you will have a chance to unmute, to come on camera, to get to know each other and to discuss. So I'm honored to be introducing today's speakers, Rebecca, Petra, and Heather. I'll be introducing them and then passing it over to them to begin their presentation. Sonia is also going to share their biographies in the chat for you. Rebecca Haynes-Saw is an associate professor in the Department of Community Health Sciences, Cummings School of Medicine, University of Calgary. She's a public health sociologist with a PhD in behavioral health sciences and addiction studies from the University of Toronto. Her research interests are in public health and harm reduction approaches to substance use and drug policy reform. Her recent projects have focused on youth and young adult cannabis use and opioid use, the family context of substance use, and parent advocacy for action on Canada's overdose death emergency. Petra Schultz lost her 25-year-old son, Danny, to accidental fentanyl poisoning in 2014. She is one of the co-founders of Moms Stop the Harm, a network of Canadian families impacted by substance use-related harms and deaths. Through the lessons learned from her personal experience and by sharing Danny's story, Petra has become an advocate for drug policy reform to reduce the harm associated with substance use. She believes that substance use is a matter involving human rights, and health must not be criminalized. Petra represents families with lived experience in Health Canada and CCSA advisory committees. She's been a speaker for TEDx at rallies, conferences, community meetings, professional organizations, universities, and all government levels. She contributed to the anti-stigma campaign CBRCanada and research projects related to her advocacy work. Last, Heather Morris is a registered nurse with a PhD in Health Services and Policy Research from the School of Public Health, University of Alberta. As a former public health nurse, her research interests center around public opinions of harm reduction and how individuals with lived experience, bereaved mothers in particular, engage in advocacy to shape drug policy reform in Canada. Heather is currently a postdoctoral fellow with the Faculty of Medicine and Dentistry at the University of Alberta and the Inner City Health and Wellness Program attached to the Royal Alexandra Hospital. She has volunteered during her PhD studies with the Boyle Street Community Service Streetworks Van and currently sits on the board of directors for the Alberta Public Health Association and Alberta Alliance, who educate and advocate responsibly. So I now pass it over to the three of you to begin your presentation.
Thank you, Amanda, for the kind introduction, and thank you for inviting us for this presentation today. So I'd like to begin to acknowledge that I'm on Treaty 6 territory, traditional lands for First Nations and Métis Region 4 in Amiskwacis, Waskahyk, and traditionally colonially known as Edmonton. To give you a next slide, please, to give you a brief outline of what we will be covering in our presentation. I will begin by remembering and honoring loved ones we lost, including my son Danny, explaining a bit why we have a drug poisoning crisis and what we do at Moms Stop the Harm, the organization I co-founded. Then Rebecca and Heather will speak about engaging in community-based research, and Heather will also report on some of the findings from our studies that we engaged in together. Next slide, please. This is my son, Danny. Danny died in 2014 from accidental fentanyl poisoning. Danny was one of the early victims of the crisis before fentanyl was in the news and before the death rate had climbed to the historically tragic level that we are experiencing today. Danny started using with OxyContin, and I always consider him to be the poster boy of drug policy failure, because he started with prescription drugs that he obtained illicitly, but he died from toxic street supply, which was the only thing available to him at the time when he relapsed and died due to changes that had been made to the supply system. And I'll be speaking a little bit more of that later in my presentation. We did not know initially that Danny was using substances. For many, stigma causes them to hide their use, stigma and of course the criminalization of substance use. And Danny was a master in disguise. In all three photos, he was either at the time using or had very previously used. It is something that we see commonly, that the images that we imagine are the ones of people who are homeless and live with other health challenges. but many people who use do so unbeknownst to their family, friends, employers, neighbors. After Danny disclosed to us that he was using and we tried to help him, we did not understand this, how we would support somebody in substance use. We didn't understand the overdose, and we did not know anything about harm reduction. We were told to practice tough love and that he had to hit rock bottom. I never believed in either of these concepts, but yet I also did not know how to support him with a harm reduction focus and how to keep him alive. In the end, what killed Danny was not the fact that he took drugs, but that the drugs available to him had become so toxic. And the same is the case for so many. What stands out for me about the drug poisoning crisis, that those in power and the general public often don't know and sometimes don't seem to care of the extent of the crisis and what needs to be done to solve it. Next slide, please. Substance use and overdose can affect anyone. These are the photos of loved ones from some of our Mum Stop the Harm members. You will see in the photos, people are predominantly, they're very young, come from all walks from life. Here, you probably have more white faces than you would have typically, but what we find in our community that sometimes when you have privilege, it's easier to speak about the stigma that you face with your loved one's substance use. But people from all socioeconomic, ethnic, and cultural backgrounds in all regions are affected. It's one demographic that is most at risk: men aged 25 to 39, most of whom who use alone. In BC and Alberta, over 80% of the victims are men. Most use indoors, most in their own homes. Certain professions are at higher risk, like men in trades, and people in culinary arts, people living in camps away from their families. The reasons why people use varies widely, but the common themes, especially when use become problematic, is physical or mental pain, trauma, adverse childhood experiences, lack of hope. The majority of our loved ones who died struggled with mental health issues. But while substance use can affect anyone, who is disproportionately affected are Indigenous people. Last year in Canada, 21, and it continues to be at this rate, 21 people die every day from substance use. But Indigenous people in BC and Alberta are 7 times as likely to be affected by death, but also hospitalization related to drug poisoning, which of course speaks to the TRC recommendation that is the theme for today. Next slide, please. If you look at drug poisoning deaths in Canada, we've been keeping stats in 2016, and since then, over 30,000 Canadians have died. This number does not include my son Danny, who died in 2014. The highest rates are in BC, Alberta, and Ontario. It is the drug toxicity that's the majority of the driver. Over 90% of the deaths are from toxic drugs supplied from street drugs. And as I mentioned earlier, this also increases rates of hospitalizations, as shown on this slide. Next slide, please. Here you see representation on maps with dark purple represents a rate per 100,000 over 20. And I think public health agencies should change that, because in many regions over 30 and up to 75 per 100,000 was recently reported in the Yukon. During the first 2 years of the pandemic, we saw a steep increase with over 90% of apparent opioid toxicity deaths increase compared to the 2 years before, which is staggering. This is related to increased isolation, but also increased toxicity of the street drugs. And Over 90%, to repeat, over 90% of the deaths are due to toxic drugs, not prescription. In Alberta, an inverse correlation between opioid prescribing and overdose rates has been shown. Next slide, please. Through the lack of health warnings after Danny died and the rising number of deaths and our experience with the health system, I started to speak out and reach out to media and met my fellow co-founders, Lorna Thomas and Leslie McBain. Together, we founded Moms Stop the Harm in 2016. And today, there are over 3,500 families that are part of our network. Most in BC, Alberta, and Ontario, but now we have directors from BC to Newfoundland. Next slide. Our organization engages in peer support and in advocacy. The advocacy involves meeting with political leaders. We do a lot of media work, talks and presentations like I'm doing today, anti-stigma, anti-discrimination campaigns, and we are represented on various committees and commissions and on research projects such as this one. Next slide. The other aspect of our work are our support groups. We have Healing Heart groups for families who've lost loved ones, and we have Holding Hope groups for families for loved ones who are using substances or in recovery. Our Holding Hope groups don't take a tough love, but take a harm reduction focus to support. To illustrate a bit what these groups mean to you, I'd like to share a couple of quotes from a Holding Hope group. Finding hope after 7 years of struggling in silence in regard to my daughter's addiction was life-changing. I felt like finally there is somebody I can talk to who gets it. And from somebody from a Healing Heart group, this is not something I could get from traditional grief support group. So I'm eternally grateful for the lifesaver of Healing Hearts that has allowed me to speak honestly and openly about my broken heart. These groups, by the way, are free to families across Canada, free of charge. We don't have local groups everywhere, but we have online groups that spread the country, and you can find the information on our websites, Healing Heart and Holding Hope Canada.ca. Next slide, please. To summarize our aims for Moms Stop the Harm, one of our key aims is a safe, regulated supply to address the fact that so many deaths are from the toxic street supply, and there is no other way of addressing it. If you think it's an addictions crisis, it is not an addictions crisis, because we have people dying who've maybe used once. Most recently, we had a mom from Calgary join us who lost a 13-year-old child who had only used once. So it's a toxic drug supply we need to address. We need to decriminalize people who use drugs, so people don't hide their substance use and die alone because of stigma and shame. Harm reduction needs to be available in all provinces. There is a high range of inequity in Canada. We need to offer evidence-based treatment, and for opioid use, that means opioid agonist treatment, various forms, but also offering injectable opioid agonist treatment to people where traditional treatment has not been shown to work for them. We need to work on upstream prevention, and I'm quite sure this audience understands what this involves. Of course, in addressing poverty, trauma, especially colonialism, and working to address the recommendations of the Truth and Reconciliation Commission is part of that. We in Moms Stop the Harm, and I'm glad that me being here today addresses this last point. We call for full inclusion of people with lived and living experience and their families in all aspects of this, including research and any decisions that affect us. At this point, I'd like to, for the next slide, hand over to Rebecca.
Hi, everyone. I'm Rebecca, as you know, and I'm coming to you from Treaty 7, which is the territory of the Blackfoot, Stoney Nakoda, Kainai, and Piikani nations, also home to Métis Region 3. And I'm at the University of Calgary and at home today. I'm really grateful to have Petra lead, and I think that speaks to, as she just mentioned, how we put people with lived and living experience at the center of our project and as equal partners. and as leading with their knowledge and experience. And we're very lucky to have Petra, who's such a skilled presenter. And I say not in a patronizing way that the parents we've been fortunate enough to work with also have PhDs in drug policy, because their level of knowledge and ability to communicate what needs to change about policy is on par with anyone I've worked with in the academy. So here you see Petra. I'd also like to introduce the founding community partners for this project, which was Donna May, who was based in Ontario, and Jennifer Woodside, who was based in BC. They've since retired and moved on to other work and activities. But it was actually through hearing Donna and Jennifer on CBC Radio on The Current when I first moved to Calgary from BC that I was introduced to mothers and parents family policy activism. And I was fortunate enough soon, being based in Alberta, to meet Heather and Petra based in Edmonton to start planning and organizing this research project, along with partners Elaine Hishka and Emily Jenkins based at U of A and UBC. Next slide. So embedded in this project and how our message dissemination and some things that fueled advocacy and activism arose from was a core qualitative community partnered, community engaged research project. And so we approached this having these organizations of parents that were established and emerging and, you know, unfortunately continuing to grow exponentially during the time that we started the project and since, due to Canada's as Petra's just outlined, rising numbers of drug poisoning deaths. To have these groups at the center. And when I originally approached the organizations, I was shocked that no researchers were interested in this topic. And research, of course, isn't the be all and end all. And community groups, you know, do a myriad of things that are not necessarily dependent on partnerships with academics, that are very meaningful to communities, such as the mutual aid and support that parents provide. But as you can see from this webinar and other activities, research is one way to document, to disseminate, and to build capital for people through partnering with academics who know how to position evidence and know how to collect evidence in a meaningful way. So that's what we did. And I have to say that with Heather leading, you know, a major portion of the interviews and with partnership through Mom Stop the Harm and other groups, this was the fastest recruitment and data collection that I've ever seen in my career, because it really spoke to the fact that parents were wanting to come forward in spite of the stigma. Even with it being an anonymous and private project, people wanted to include their story, to include their names, of course, which, you know, wasn't part of our protocol, but people were just extremely willing to come forward, and this happened very quickly. So we collected 43 stories from across Canada. We did some oral history interviews of the 3 founding organizations. And Petra's told you a little bit about the sample and why racial and class privilege may facilitate some people coming forward. And in this case, due to the age of people dying, you know, most people were, you know, into their mid-40s, heading into middle age. We focused only on mothers, and you can see a little bit about the gender split in the people's children and their marital status here on this slide. So it just gives you an idea about our sample. Next slide. So now I'm going to talk about a few of the principles that guided our project and how we learned to work together. We had some great ideas, and I think we all came to this project in a spirit of collaboration. But of course, working as a new team and working between and across institutions and community groups, we had to learn as we went. And so we wrote up these 4 principles that helped us to establish a meaningful partnership and how we continue to work together. And we've written this up in a paper, and we present at conferences, and hopefully it will be a publication in the next little while. But I think one of the most important things was ensuring representation. We spoke to the tricky issues around those dynamics already at length. But just in general, mother and parent can be a loaded term, of course. And so we took a very open approach that a mother or parent would be anyone who identified as woman or who identified as a mother. And so for me and my background, that included, a focus on being open to people who were adoptive parents, kinship arrangements, a whole bunch of ways that people identified as the mother or parent of a child who had overdosed. So just being inclusive of those family situations was important to guide us. Next slide, please. This is a very, fraught domain in the university, which is as most of you know, working in the space is, subject to so much bureaucracy. Recently, we have a move also into compensating people only through gift cards and not being able to provide cash compensation in the community to community members, which is a problem I've been struggling with in my context. But guided by a lot of the principles that people who use drugs have established. And here's a great report from the domain of HIV/AIDS community legal group in Ontario. The principle that comes from disability activism that many of you are familiar with in community-based research of nothing about us without us. That should also translate to meaningfully compensating people for their time. So I felt, and we were also in agreement among our team, that this is a way to push for the maximum compensation that, a government research grant can provide. So we made a strong case that about 10% of our grant budget could be divided amongst the parent collaborators in this project to make sure that they received a generous stipend for their time. And there's other ways that you can employ people as research coordinators. That wasn't appropriate for this team. But all that to say, people need more than a $50 gift card when they're showing up, when they're committing their time. So this was very important to us, and we built that in as we got new funding. Next slide. Working with a community based project, as many of you, I'm sure, are experienced, has different types of ethical considerations about how you're going to proceed with data collection, data sharing, and data mobilization. Coming from a sociological background, I'm used to being highly critical of what we hear in interviews and theorizing things and using that to push back against norms around health. This project was in a totally different spirit of really engaging authentically with community, hearing what their concerns were, and not critiquing what we heard in a way that was negative, but rather, focusing upstream to critique systems that lead to, systemic violence and stigma and a lack of appropriate care and response to the death emergency for families and people affected. So in this way also, there was practical things around data sharing that we wanted parent partners and community to be engaged with the data. But of course, given the fact that there was different groups and even within groups, we wanted people to share freely and know that their stories would be protected. So we made decisions early on that transcripts would only be shared when they had been coded, so never raw data. And so that people would have a chance to collaborate as authors and to see the summaries of data, but wouldn't be reading, individual transcripts and so on. And so in that regard, I think we were able to ensure that all the data that we were thinking about and the codes we were developing and the analysis we were developing was respectful and was vetted by our collaborators and partners. And I think increasingly more broadly in the Canadian drug policy space, we are seeing people who use drugs, people who are affected, people from the community as authors on publications and as engaged in the analysis and write-up of projects, not just shoved off to the side. Next slide. So that really speaks to this next slide here, where Petra is featured with her photos of Danny. Such a powerful image that every time I see it, it still sort of makes my throat catch. And really, I think if parent collaborators are going to come forward and share their stories and share their families, and their loved ones, deaths, then we owe it to them to put them at the forefront and make sure that they feel ownership in the dissemination of the project results. So not just being featured in a publication, but where they want to be featured and where they are willing to be featured, having them as co-presenters. I like to sit back and, have Heather and Petra do the amazing job they do most times, going around and presenting, having them lead presentations, and having less academics in the room and more of a partnership with parents. I think it's also important, though, to recognize when an audience might be hostile, when people are going to need more support. I know the moms are tough, but also thinking carefully and using a trauma-informed lens, that sometimes people might not have the energy or the bandwidth to share a story or to give a presentation. Next slide. I'll pass it over to Heather. I'm sorry. I got caught up and now it's time to transition to Heather. Thank you so much.
Thank you, Rebecca. So with respect to dissemination, so far we've published 3 manuscripts with a 4th paper in the works. And we thought we would just tell you a little bit, share a little bit of information around these 3 manuscripts. For our first manuscript, we utilized multi-site qualitative analysis to help us better understand how social context informed bereaved mothers advocacy efforts across 3 different regions in Canada. These being BC, the Prairie Provinces, and Eastern Canada. We found evidence that mothers' advocacy was in fact shaped by the unique social and political ethos of these 3 geographical regions, which influenced their aims, their messaging, and their tactics. So for example, while mothers in BC spoke of public awareness of the drug poisoning crisis in their province as being somewhat limited to the downtown east side, they also acknowledged the significant gains that were made in policy reform within their own province. As a result, many of the BC mothers that we spoke to at the time, which was in 2017, were focused on seeking changes at a federal level. So that being changes around decriminalization of drug use and enhancing safe supply. Now, this was in contrast to mothers from the Prairie Provinces who had to fight against more socially conservative values and beliefs in their attempts to persuade the public of the many benefits of harm reduction. So messaging from bereaved mothers in the Prairie Provinces was more focused on increasing public awareness of substance use, addressing stigma, and increasing the need for treatment and harm reduction services. We did find a number of shared narratives across the regions, one being that mother stories were seen as a powerful tool that can complement other forms of knowledge and evidence in helping to shape public and political beliefs. Next slide, please. So for our second manuscript, we set out to explore what it was that compelled mothers to do this kind of work and what kind of impact it had on their personal lives. The women that we spoke to were motivated by the emotions that are common with grieving the loss of a loved one. So despair, tremendous disappointment, oftentimes in the healthcare system, as well as anger. And one of our participants, for example, stated, "I was pissed, I was angry, I'm angry." And I think anger is not a bad thing, it's where we get change. Others were motivated by those around them. Some were motivated by seeing positive changes from one's advocacy or personal calling or need to alleviate the shame and the stigma that we've already spoken to. Hope was another strong motivator, as well as just a strong belief in social justice values, as well as the need to honor one's child. So these were all additional important motivators to many of the women that we spoke to. While advocacy brought with it feelings of personal empowerment, as well as a solace in connecting with others, it also brought with it this kind of juxtaposition of pain versus healing. Hence the title of our paper referring to this double-edged sword. One of our participants likened the experience to continually pulling a Band-Aid off. You know it's going to hurt, but it's just something that she had to do. Next slide, please. Our research question for manuscript number 3 was, how do mothers who have lost a child to substance use describe their experiences of media advocacy? And this was one of the papers in my PhD thesis. Participants here described the news media as being very powerful allies in their efforts to educate members of the public, change public attitudes, as well as influence policy and support of people who use drugs. Many tried to find this right balance between talking about their child and their own grief experiences, while also at the same time advocating for practice and policy solutions to the overdose crisis. In addition to expressing a number of reasons for why engagement with the news media is so important, participants shared with us a number of strategies that they used, such as reaching out to news media outlets directly and preparing talking points ahead of time. However, interacting with journalists also brought with it a number of challenges, and these included things like fear of news media complacency, insensitive comments by journalists or members of the public, the potential for sensationalism, as well as the potential to have one story misrepresented. Next slide, please. So equally important to publishing academic papers was finding other ways to share our research findings with the broader community. So we started off in 2017 by hosting a public forum called the Family-Centered Approach to Substance Use in Alberta. This forum was attended by over 100 people, members of the public, and presentations were delivered by our three parent partners, Jennifer, Donna, and Petra, featured in this photo here, as well as Marlis Taylor of Streetworks and Dr. Hakik Varani, an addictions physician here in Edmonton. And then following this, we had an afternoon roundtable discussion workshop that was attended by stakeholders representing 20 different organizations from both Calgary and Edmonton. And then about a year after that, the National Harm Reduction Conference was held in Edmonton. So Petra suggested that we organize a satellite event that would be open to the public. So we did that and had about 150 participants there as well. And it was promoted through the media, which was great. Next slide, please. We developed this report to share the results of our work with our community partners and stakeholders, as well as all 43 research participants were offered a copy of the report. If you're interested, please go to Stop the Harm website because it's listed there under the research tab. This report provides the background for the study, a high-level summary of what we found, how we are sharing our research with members of the community, and what we plan to do next. Next slide, please. In 2018, our research team was awarded a $60,000 Government of Alberta Opioid Public Awareness Grant to develop and disseminate short digital videos that share messages and stories under the theme, What Families Want You to Know About Opioid Stigma and Harm Reduction. And I'll just say that at the time that we received this grant, the NDP was the party that was governing the province. We developed and filmed the See the Lives video series in partnership with Phil Haig, Kim Porter, Donna May, and Petra. Kim, Donna, and Petra each have a child whose death was attributable to substance use, and Phil's son's death was related to suicide and substance use. Each film is about 90 seconds long and features each parent listening to an audio of a letter that they wrote to their child with a call to action to end the shame and the stigma that surrounds substance use, as well as the need to support harm reduction policies and practice. And we promoted the films in two primary ways. The first was the c-beyond.ca website, which is an online hub where we shared the videos, a list of resources where people can seek support, including a national crisis line number, information on where to access naloxone kits across Canada, a study guide, and an online survey. And then we also had the hashtag See the Lives Project YouTube channel as well. To date, we've had over 161,000 views on YouTube and 25,000 website page views. Next slide, please. So prior to the pandemic, we did manage to disseminate the film project at a number of different events face-to-face, as you can see on this slide here, different community events across Canada. The project was also replicated in Scotland in consultation with ourselves. So they had seen our project, I guess, through social media avenues and reach out to Rebecca, and we were able to work with them and provide some guidance to them as well. The films were selected by Health Canada for screening at their anti-stigma display at the Commission on Narcotics United Nations Office on Drugs and Crime meeting that was held in Vienna in 2019. Number of local harm reduction agencies, well, one in particular that showed it to their staff here in Edmonton that we're aware of. Petra and I were able to show the film at Harm Reduction International Conference in Portugal back in 2019. And thankfully, a number of news media outlets also carried the story in different cities across Canada. Last, just a few points about our evaluation. We asked people who visited our website to answer a short survey. 71 respondents. 73% of respondents told us that they would be extremely likely to recommend the videos to a friend or colleague, and 93% of respondents were either very affected or extremely affected, that is emotionally moved when watching the videos. Social media advertising was absolutely essential to driving the high numbers to the website and the videos. So we know that 86% of visitors to the website were from Canada, and the rest came from 81 different countries around the world. Interestingly, Twitter would not initially run the advertisements on these videos, as they said it violated their policy against, quote, promoting drug use paraphernalia or drug use sites. But we managed to get some advertising through Twitter on the second round of advertising that we did. We know that more men watched the videos than women, and we didn't have a lot of Twitter traction with the hashtag See the Lives between March and April. But it was used in a number of different cities in Canada, and the message was picked up and retweeted by Andre Picard of the Globe and Mail, as well as Janine Interlandi, who is an editor at the New York Times. Next slide, please. We've given a lot of thought to the benefits and challenges of our partnership over the years, which we'd like to share with you. First of all, we recognize that we all bring very unique skills and knowledge to the table. And I think that there was a great amount of respect for everybody, because just recognizing that everybody brought something different and that we were all able to benefit from that. As a former public health nurse, as a graduate student throughout this process, it also made me feel like I'm part of a community and a larger movement, larger movement of people who share the same values as I do with respect to public health and social justice. And it also helped me gain a sense of how research intersects with policy and public health practice as well too. I've been mentored along the way by so many people, not only my university colleagues, but also very much my community partners. Petra will probably remember the first time that I ever had to do a media interview myself. I was absolutely terrified, and Petra, who's done hundreds of these, said to me, "Don't worry, Heather, we'll do this together." And that just made all the difference in the world. Mum Stop the Harm has also told us that it allows them to have ready access to content experts without the additional expense to their organization. Another advantage for them has been it helps to take their advocacy message to different audiences, and in many instances, audiences that can influence healthcare provision and policy making as well too. But of course, with everything, there's always challenges. And one of the things that became evident very early on was this recognition that this is very emotional work, in particular for our parent partners. Communication can always be a challenge whenever you have different people working in different provinces. We all know that community-based participatory research can take additional time, and we also had to sometimes find creative ways to help pay for making certain that different voices, different partners from our research partnership were included at different tables. So when it still comes to presenting at conferences, we're always looking for conference scholarships to help finance everybody's travel, or at least myself and Petra or Rebecca in that regard as well too. So the bottom line is mutual trust is absolutely essential in each other as professionals and as partners. So in conclusion, to our knowledge, our research partnership addressing the advocacy work of family members around drug policy reform, as far as we know, is the first of its kind in Canada. We're extremely grateful to be able to leverage the wisdom of families who represent an important but currently underutilized resource in substance use research and drug policy development. We want to say thank you to Mum Stop the Harm, mumsDU, the voice of the family, U of C, UBC, U of A, funding from a variety of different sources. We also want to thank Community-Based Research Canada for supporting our work. And most of all, thanks to the women who have been interviewed and to our parent partners who continue to teach us about advocacy every day.
Thank you, Heather, Patria, and Rebecca. I hope everyone watching can see why this project was chosen as the winner of the CBRCanada Award for Community University Partnership. This project highlights and exemplifies so many of the key values and hallmarks of community-based research, from the way they took a very community-driven and participatory approach. They took so much care to the equal sharing of the research with people with lived experience, and they did an excellent job with knowledge translation, really mobilizing the community through the ways that they shared their knowledge. So we have about 10 minutes now for a question and answer period with our three presenters. I'm going to stop sharing my screen so that we can all see the presenters, who I will highlight for everyone here. We have one question in the chat so far, so we'll start with that question. For those of you who are still thinking of questions, please enter your questions in the chat for the presenters, and we'll address them over the next 10 minutes. So the question that we had in the chat so far was from Justin, asking about what some of the current policies on drug or harm reduction responses in Canada are right now.
Maybe I can kick that one off. The responses are as many as we have provinces and territories, plus one federal government. There is no coherent response. There are a lot of inequities across the country. We have from the federal government strong support for harm reduction. Under the current government, we have been able to see an increase in the opening of supervised consumption services on overdose prevention side, which are proven to save lives and health outcomes. That is positive. We have verbal support from the government for safe regulated substances, but not what I would call a public health approach to it. We have pilots in a number of provinces, mostly BC, Ontario, and some Atlantic provinces. But in BC, for example, it's estimated that about 80 to 90,000 people use substances from the illicit market. That is people who might use casually, or those who use in a more problematic kind of way. And of those, only about 900 have access to safe supply. That is a huge problem. In BC, the government on paper embraces and supports and funds harm reduction more so than in any other province, but yet the response is woefully inadequate to the size of the crisis. In Alberta, in the prairie provinces, Alberta, Saskatchewan, Manitoba, we are waging war against harm reduction, and the results are devastating. In Saskatchewan, T-shirt sales fund a supervised consumption site. In Alberta, we've seen consumption sites closed. In Manitoba, they never had one. In Ontario, it is sort of in between, a little better in some regions, but not consistent. And the same holds true for the Maritimes and for Quebec. So overall, Canada has a failing grade, and the problem is that we are still seeing it as what we call an addictions crisis, or so many people call it an opioid crisis. Please don't ever call it an opioid crisis. Opioids are not at fault. It's a toxic drug crisis. My son did not die because he used substances. He died because the substances he used were toxic. If he had just used substances, he sought treatment. A day before he died, he asked me to make an appointment with his doctor and psychologist again. He did not live long enough to attend that appointment. So that is what I always say. It's not an opioid crisis. It's not an addictions crisis. It's a crisis of toxic drugs. And eventually, as a society, we have to come to terms with the fact that only legal regulation, and regulation with a capital R, with the public health focus, not commercialization like we have done with cannabis, for example, is, in my opinion, the answer. And not just in my opinion, experts support that, and that is our organizational position. And that is what the research tells us. But it's not where politicians want to go, because it's not the hill they want to die on.
I would just add one quick follow-up to Petra's excellent points and concise summary of Drug Policy 101 in Canada is that this is one of the most transformative things that we attempted to bring out of our project, is that if you think about parents who are bereaved and experience probably the worst type of grief and loss that you can imagine in your lifetime, you would expect them to be seeking, criminalization, getting tough on drugs, cracking down, and extending what we call the war on drugs and prohibition tactics. Certainly some of those narratives and groups exist in Canada, but the largest voices among bereaved parents are people who support harm reduction and drug policy reform, the critical mass, I should say, of voices. And that's truly transformative because as we grow up in our homes and communities, many of us have been affected by addiction. Many of us have heard these messages or experienced supporting a loved one. And we're told, get tough, set boundaries, push people out, give people interventions, give them ultimatums. People deserve what they get if they make the choice to use drugs, really harmful, horrible things. These are toxic messages. The drug supply is toxic right now. And people, as Petra has shown in the slide, from all walks of life and all backgrounds are experiencing, these horrible, tragic outcomes. So that has been like a really big shift that I think we've brought that message to lots of different forums through this project.
Thank you, Petra and Rebecca, for answering that question for Justin. I haven't seen any other questions come in the chat yet. If you do still have questions, we have a couple minutes left, so get them in quickly. One question that I have for each of you, you've done so much work in terms of disseminating your knowledge, sharing it in different forums, getting the community to really mobilize around your findings. Has there been anything done in terms of policy advocacy to government to change some of the policies in Canada or in the provinces you've worked on? And if not, if you could make a change in policy, what would you hope to see change based on what you've learned in your project?
I'll just speak to that to begin. I think, first of all, it's important to recognize that the mothers that we spoke to, although a lot of their advocacy work might appear to only be aimed towards changing public opinion, I think Petra would agree that a huge part of what they're trying to do is change the opinions of politicians who have the power to make changes at different levels of government. And so we interviewed, some of the mothers that we interviewed have spoken to leaders at all levels, mayors of cities, ministers of health at the provincial and the federal level, the prime minister, like you name it, like they have had an audience at the highest levels of government, which has been very interesting to see over the years. And I think also encouraging to some degree as well too. So that's been a tremendous part of their own advocacy. But I would also say too that where it has been feasible, the researchers on the project have also engaged in certain degrees of political advocacy as well too. And we've certainly, I guess, speaking for myself, that was one of the most amazing learning outcomes in terms of my PhD, was how to learn how to be engaged in that respect and reach out to politicians and work with politicians to try to move some of these policies forward. So just as an example, recently there was a public panel presentation with Gord Johns, who's a member of parliament from BC, who was coming through the city on a tour trying to promote legislation that he had put forward in parliament. And so Petra asked me to moderate that, and we had a great turnout, and both in person, but also virtually as well too. So that was an example of how Petra has encouraged me to participate in some of these initiatives.
It's excellent to hear the reciprocity in your project in terms of, you know, the researchers, the lived experience folks all coming together for research, but also for advocacy, and this model of kind of co-learning that you've had together, being able to share your skills and experiences with each other. Excellent. So we're at 12:55, which is the end of our question and answer period, as well as the end of our formal webinar portion of this event. So I'm going to pull my screen
Amanda,
share back.
Sorry, Amanda, can I quickly give a quick response to Morgan's question about safe supply approaches in the chat?
Sure. So
yeah.
I see one question here from Morgan. Did your participants express a preference for how harm reduction or safe supply would be provided, either through a medicalized or institutionalized approach or through a more grassroots approach? Go ahead, Petra.
From our perspective, what is really needed is grassroots approach and putting it in the hands of people who use drugs ideally. From a policy perspective, that is very complex, but we can provide exemptions from the Controlled Drugs and Substances Act to make that happen. There's a group in Vancouver, the Drug User Liberation Front. They've asked for an exemption, and they have created a compassion club model. And in a compassion club model, they obtain substances, they test them, they package them, they label them, and then distributing them through the Compassion Club members. Now, right now, they're kind of operating in a gray zone, but if groups like the Drug User Liberation Front, DULF, could be granted an exemption, we could see models like this in other areas. Overall, we need a variety of models. For some people, a prescriber model works, but it always creates bottlenecks. We need also a public health model, and there is work being done on how such a public health model looks like, but there needs to be more push for that. And it really needs to be the public speaking out in support of these approaches for politicians to shift and be more open to this change.
Thank you, Petra. That was a very important question, and I'm glad we had the chance to address that. So as we close out now the formal webinar portion of this webinar live discussion event, for anyone who does have to leave or pop off before we move into the live discussion, we want to remind you to please stay in touch with us. Sonia will share the link in the chat where you can go to sign up for our e-newsletter to find out about upcoming events. And thank you to our presenters, to those who asked a question, to everyone here listening today, and everyone watching this webinar later online. So I'm now going to stop the recording.